This session that is dedicated to a case inspired to the principles of the Surviving Sepsis Campaign. And my name is Massimo Antonelli, and my co-chairman is Jean-Louis Vincent. We are waiting for the third one, that is Daniel De Baker, but I think that it's going to reach us in the very next few minutes. In the meantime, I try to present you this case, and then we can discuss step by step all the different possibilities that we may have. This is a male, 42 years old, a bank clerk. He presented fever, odynophagia, dysphagia, some redness of the neck and swelling, and he had a dental care 2 years before. And he is admitted to the emergency department on Urban Hospital on 15 May at 18 into the afternoon. The echo that is performed at the neck level showed an increased volume of the salivary glands and adjacent tissues, heterogeneous structures like an inflammatory process. And there was also thin liquid stripes and suggesting phlegmon in the subcutaneous adipose tissue. So apparently a situation which is quite dangerous. Has been performed a chest CT scan, and then there are deep neck soft tissues emphysema spread into muscular plans, gas bubbles in arterial mediastinum and paratracheal area. Then it is admitted to the ICU at the 23 hours. His Glasgow coma score is 14. This is immediately before the admission to the ICU. Tachypnea, 32 bursts per minute, atrial fibrillation, fibrilloflutter to be precise, fever, a systolic blood pressure 95, and he had, as mentioned in the very few initial slides, submandibular and parotid gland swelling, and an eschar of the suprajugular area of the upper chest wall. Well, so looking at this situation, my first question is, should you admit this patient to the ICU, or could you consider these patients at risk for some given reason? What should you have done? What do you think in the meantime, Jean-Louis?
Would anybody not admit the patient to the ICU and would defend that case? No, I think the patient should go in the ICU. That's really a very severe circumstances. We are particularly concerned by the presence of gas in the mediastinum. Yes. The atrial fibrilloflutter in this young individual may, of course, be due to the sepsis. We don't know yet whether he is in shock or not, but it could be also due to the process involving the pericardium, actually, and inducing the fibrilloflutter.
Even though there is no clear clue in favor of the involvement of pericardium, but physiologically this should be the case. Yeah. Because the stimulus should come from the mediastinum.
So as always, you look at the three things to be done: infection control, hemodynamic stabilization, and modulation of the sepsis process.
Maybe I would say something more. If we look at the characteristic of this patient, wherever he would be, I think that these things should alarm us, because his Glasgow coma score is not perfect.
I think we need to consider the treatment of the infectious process and the hemodynamic stabilization. The treatment of the infection process, of course, will be held together with the consultants that you will call on this case. And for the hemodynamic management, we would like to know if this patient is in shock or not. But in any case, he will be a VIP. We will have to look at V, ventilation, what about oxygen administration, I, fluids, and perhaps P, pump, maybe vasoactivations. So we would like to know more about it. He is hyperventilating, 32 breaths per minute. We would like to see his blood gases and see whether he is really hypoxemic or if he has a sepsis-induced hyperventilation. But before that, we would like to know, we see a systolic blood pressure of 95.
Which is not that bad, but you know, it's 95, it's not perfect.
But we don't know the diastolic yet, and we would like to know the 3 windows. So we know that this Glasgow Coma score is 14, so probably he's obtunded, a bit disoriented. But what about the skin perfusion, the urine output? He has been there for several hours, so perhaps we could already have some information about the urine output. And of course, the lactate level.
So I would like just to ask you another question. If you had a patient like this, regardless the origin of an infection with this kind of signs, outside of the ICU, should you consider these as at-risk patients or not? Yes, and maybe this is the reason why. Very recently, there were also the new definition of sepsis, not only the new guidelines of the Surviving Sepsis Campaign. And one of the, I would say, most valuable things, at least for those patients who are outside the ICU, is the identification of these quick SOFA criteria that can be a good indicators for a situation when, in presence of infections, the patient is ready or prone to deteriorate. And in this case, I think that our patient had all these 3 things, because he had indeed a tachypnea, he had an altermentation, and the systolic blood pressure was not so bad, but it was below 100. So all these alarm systems should just lightening in our mind the idea that this situation may evolve. Would you like to say something, Daniel?
Yes. What is exactly the additional value of these numbers compared to what you have on the other side? I mean, if you look back rapidly to the blood pressure, I mean, I'm sure that 95% of the emergency physicians will be worried when they see a blood pressure below that level. Maybe the real interest is the 2 other signs, meaning paying some attention to the tachypnea that is sometimes overlooked by colleagues, nurses, and that indeed having this 22 cutoff, I mean, is already something. Of course, your patient is much more severe with a 32, and with 32, I'm sure that most physicians would have been worried. With a slower rate, perhaps, indeed, this can be slightly missed, and people may react a little bit less. And probably the other very important aspect is the slight alteration in cementation. And even though I totally agree with Jean-Louis that this is one of the windows that we are looking as intensivists, sometimes our colleagues, especially in the ward or the emergency department, fail somewhat to look at it. So probably hypotension is one of the signs, but hopefully we need to have 2 of these signs to be alerting. And I think that you can have patients with just alterations in cementation and tachypneic, and I guess that this will be really in that window of patients that this cue so
one
far
of
will be
the
most
important things. But personally, I stay along the same line that Jean-Louis several times has underlined, that these criteria are not certain criteria useful for the ICU physician, for the intensivist, but can be really valuable outside the ICU in order to just promote a form of attention to these conditions in the general ward or in the emergency department. But on top of that, in the ward, because there often some of these criteria are disregarded or analyzed lately, which is obviously a problem in these kind of patients where acting earlier is much important.
As I will develop this afternoon, we actually developed it primarily for the wards. So the nurses would have another argument to call the doctor on the ward when a patient meets these criteria. As we know, too often the primary physician is busy in the operating room, in the outpatient clinic, elsewhere, and answers the phone saying, yeah, I will come, in 10 minutes I'll be there. And the patient is not doing very well. So with the Q SOFA, you could even perhaps have a a reason to call a team that would go to the floor and check the patient right away. So it's primarily for the regular floor, as you say, Massimo.
However, please, this is indeed this case report is intended to involve also your participation. Would you, excuse me, would you please to bring a microphone?
Well,
Thank you.
Already shout, maybe.
Okay.
So this is the reason why I advocate for the nurses, because I'm a nurse, so I'm a registered nurse, and I'm a critical care outbreak specialist. And this is the reason why we have to call the rapid response if we have to.
Yeah.
And then we have nurses cannot be intimidated, because this is, you have to follow your gut. You have to call rapid response because we are here for the patient. Patient comes first.
Although, as I indicated yesterday, you need to organize your own system in the best way. There is not one Met team system which is applicable everywhere. You may wish, as we do, have the doctors of the floor taking care of their patients before we come. Because if we have to take care of all the problems in the hospital, then we are no longer in the ICU. And we don't need to replace doctors on the floor by a team that will take care of everything in the hospital. We still need doctors on the floor. We still need surgeons who can look at a patient who is febrile. And the surgeon should not say, okay, call the team if there is fever. No. We need to have some hierarchical system, and we are there to help, but we still have doctors around that can take care of patients initially before calling us.
Any other comment coming from the audience for concerning these aspects? If not, move on. Well, the patients indeed developed a mild RDS following the Berlin definition.
We don't say ALI anymore, right?
Yes.
It's an old slide, right?
It's an old slide, I must admit. And because this is a real case, but I was inspired by this real case that occurred years ago. The patients developed a real hypotension with 8 millimeters of mercury of systolic blood pressure, and this hypotension was unresponsive to the fluid replacement therapy with some saline with in reason of 30 milliliters per kilograms within 1 hour. So this patient had a septic shock. And
I would say that even before giving the 30 cc's per kilogram of saline in 1 hour, it is septic shock.
It is septic shock.
I mean, we don't need to wait for 1 hour to say, oh, wait a minute, we will first make sure that it is unresponsive to initial fluid administration. Come on. No, it's septic shock from the very beginning.
From the very beginning.
What was the lactate level? That's very important, at least to have a baseline value.
Here it is. Here it is.
Voilà.
This is the FeO2 immediately after the intubation with a PEEP of 8 centimeters of water. And pH is not that bad, but is still slightly acidotic, 7.34. The PaO2 is 119. The PaO2, FeO2, I would say reasonable, but in the range of the mild RDS according to the Berlin definition. PaCO2 is substantially normal, but there is a reduction of the bicarbonate, but on top of that, the lactate are increased at 4.2 millimole per liter.
We don't need a bicarbonate there because, there is acidemia, 7.34, and the PCO2 is hardly decreased, so we know there is metabolic acidosis. Bicarbonate calculation is not necessary. But the patient was hyperventilating before. Now he's no longer hyperventilating. I suspect that this patient was sedated.
It was sedated for the intubation. He
should not, probably, unless he is very agitated, but it's rare. Patients with septic shock are obtunded, and they are drowsy, they are a bit sleepy, and you don't need to sedate them, because sedation can worsen the hemodynamic status, whether you use midazolam or especially propofol, that can alter the hemodynamic status more. So these patients now are no longer sedated, but I realize it's an old slide.
No, but this is the slide that we got at the precise moment when the patient was intubated. The only thing that I can add, you consider that the patient had also pain, and so he received some analgesic, and some of the sedation was related to the analgesia that we used for reduce the pain.
I suppose he needed sedation for the intubation.
Massimo, the 30 milliliters per kilogram, which I actually think it's a good thing to give fluids fast in these patients. However, It's different if they come to the emergency department where they've not received any fluids, and this patient was in the ward, I understand.
The patient was admitted to the emergency department, and I would say almost immediately moved to the ICU. So in this case, it's slightly different.
I know that the guidelines didn't make any difference of what was the origin of the sepsis in the ward. Or
Indeed.
But do you think it's different in terms of the amount of fluids that we should be giving at the beginning when we make the diagnosis of sepsis, whether you are in the emergency department or whether you've been in the ward for 3, 4,
Personally,
or 5
I can
days?
tell you that having a better monitoring would be always helpful, and at times we may distinguish if giving such a liberal amount of fluid or titrating the amount of fluid or doing a challenge of fluid in specific patients, despite what the recommendations of the Surviving Sepsis Campaign says.
But no, I mean, we all agree that when we say 30 milliliters per kilogram, just for practicality,
yes,
it's usually 15 plus 15. And if you give 15 and your patient is suddenly fine after 15, you probably will not give the other 2, and you will reconsider the diagnosis.
Absolutely
Good
right.
point.
Just a point here. You mentioned rapidly that you had endotracheal intubation, and Jean-Louis already worried about the of sedation. Did we? I mean, based on the factors you presented, it's not obvious that it was absolutely mandatory to intubate the patient because it was only mild RDS. It may worsen and require intubation later on, but with this, maybe a high flow oxygen would have been okay. You say, okay, he was hyperventilating, and maybe this could be one of the factors. Looking especially at the depth of the breath, maybe more than anything else. Could you elaborate more on the way you handle this, and especially because it was hypotensive, and the order you use the different therapies you mentioned there?
There are 3 factors that should be taken into consideration. As first, because of his tachypneic and the inspiratory swing in this patient is really deep and important, the transpulmonary pressure that the patient may generate could be sufficient to deteriorate even more the situation that we do have at the level of the lung. As second, another thing that preoccupied the physicians at that time was the already having the CT scan where some air was shown into the upper mediastinum, and then this could just anticipate the possibility of a rapid surgery intervention. So under these circumstances, maybe it is not so wise to hesitate and intubate the patients, because anyway should go to the OR.
So I totally agree with this. Just 1 minute. But then could you elaborate a little bit more on the sequence you use? I mean, because you mentioned intubation, because of course some risks that are, let's say, more for the later evolution of the lungs and the possibility of a operating room. On the other hand, we face now some sign of shock. This patient is hypotensive and so on and so on. And so do you first correct the hypotension? Do you first give fluids? Do you first give norepinephrine? Or do you go right away and say, okay, we intubate, we give fluid, we do everything?
This is a very interesting point also, because if you look at the literature and even to relatively recent publication with the high flow oxygen therapy, you may be surprised detecting some hypotensive patients and in serious respiratory conditions with a PaO2, VO2, and bilateral infiltrate since the very beginning of the enrollment in this study. And then it means that these patients were treated despite their severe condition, and at times, looking at the data, they have been published even successfully. So there is no a clear-cut way to proceed in this case. Probably a fast track, just looking at as a first approach to the high-flow oxygen therapy. Immediately thereafter, if indicated, if someone is a believer or not, may be used also for a short period of time, immediately before, just to stabilize the patient, to go to the OR, a form of non-invasive ventilation, and immediately thereafter, if this is not safe enough, proceed toward the endotracheal intubation. This could be just an indicative sequence of events that we should follow mentally in order to approach these patients.
Yeah, I fully support the endotracheal intubation because as soon as there is a hesitation, as we discussed yesterday, as soon as we raise the question, shouldn't we intubate this patient with septic shock, we need to do it. Otherwise, it may result in respiratory arrest, and that's a terrible condition. And my question, as we give the microphone to the gentleman, is why the dobutamine right away?
No, but generally, one question. I mean,
the patient will need surgery. You were not there at the beginning. The patient will need surgery.
Yeah, but you are not here now when I'm talking. I mean, the problem is this patient is hypotensive at 80. If you intubate this patient, giving sedation and he's not responding to fluids. So if you don't do anything now, this patient will collapse at intubation. And so maybe indeed.
No, but I suppose they gave norepinephrine before intubation.
So that's my point I want to make, and I think that it is very important now to realize that if you don't give right away norepinephrine in this patient who is not responding to fluids, who is hypotensive, and you're deteriorating despite the fact that you give volume, this patient will collapse due to sedation and intubation.
Just in order to reconcile these two positions.
There are no two positions we agree, but I think we agree, the three of us. Now, you cannot intubate the patient when he has
But I missed to mention, and it is my fault, I'm sorry for that, that for just...
No.
That for intubating these patients, we use ketamine in this case. Obviously, it's more protective than other things.
That's not bad. Ketamine is the only anesthetic sedative agent that will not have a depressing effect on the cardiovascular system. We should perhaps use it a bit more often.
I think we will appreciate scans because coming back to your comment regarding intubation, I would intubate this patient straight away because if you have phlegmon around salivary glands, neck is swollen, we are very concerned about airway compromise, and looking at dynamics of the process, the airway can collapse from inflammation. So I think I absolutely agree with Professor Vincent that intubation is of paramount importance just to protect airway in patients with swollen, inflamed neck and all surrounding structure. It can progress very quickly.
Yes, but the point I wanted to make, and maybe I was not clear, and that's why I insist 3 times on this, is that in my mind, we anticipate first a difficult intubation. Is this patient has something so we probably, we can give ketamine, but perhaps we will need a lot of things to try to intubate this patient because we have something in the neck. And so we know that it's not just, we put a tube and it will be done. I mean, this can be lasting half an hour or 1 hour just to get the intubation. So we may perhaps at some point forget about the hemodynamics, and this patient may die during the process. That's why I agree that we need to intubate this patient. This was another point. But I think that in my mind, we need first to fix the hypotension, or at least to prepare something to be ready to face the hypotension that will be occurring during the event.
As always, when we present a case, we need to follow the evolution of the presentation. And so very often there are a number of other questions that came out. Another point that maybe we can think about, that in this kind of unstable patient, we may think immediately before of intubation, and by using the ketamine, for instance, for sedate them, to pre-oxygenate with some short track of a non-invasive ventilation, for instance. This is something that Sami Jaber has clearly shown be beneficial and at least more protective for these patients. But this is something that was not done, I must admit. We were worried, as the colleague stressed and Jean-Louis said, that the patients had a local situation very dangerous. But you will be surprised because apparently the airways weren't so compromised, but indeed they were, and you will see later on. However, looking at the Surviving Sepsis Campaign and looking at the recommendation or the best practical statements, we stay along these new recommendations, where the idea of giving crystalloids during the first 3 hours in the amount of 30 ml per kilogram body weight being a strong recommendation, even though with the low quality of evidence, could have been the inspiring idea to follow in order to treat these patients. The other point is that the third point of this initial resuscitation recommendation says that we recommend that following initial fluid resuscitation, additional fluid be guided by frequent reassessment of the hemodynamic status. This is a best practice statement. This is a quite generical, but I must admit we should discuss how to do that, which is less clear.
But perhaps just before, and I'm sure that Jean-Louis wanted to jump on the podium to say something about the 3 hours.
Yes.
So
we spoke about it yesterday. That's the recommendation that I have most problems with. I asked our colleagues, before signing, I said, can't we change that? But they say there is no evidence, no evidence, no evidence, no prospective randomized controlled trial. So we cannot say more than that. But giving a recommendation for 3 hours, it doesn't make sense. We are speaking about early resuscitation. 3 hours for early resuscitation. That's too long. Much too long.
You know how.
So that's ridiculous.
How tough was the discussion for that? But in the end, obviously, you need to just interpret, understand what is the process that is behind, and then applying wisely this kind of recommendation at the bedside.
So.
Why the dobutamine? You have not addressed my question.
That's correct.
You put the patient on dobutamine right away, which is perhaps something that we would have done too, but for the audience, it may be interesting to discuss it.
Absolutely. I can tell you that this was done in order to suspect. This is very important. This was a clinical decision that may be not enoughly motivated and run and induced by an objective detection of a cardiac failure or hypocontractility. In this case, I think that should have been done at least an echocardiography, but it wasn't done at that time, and so the physician in charge decided to go away immediately with the supplementation of dobutamine. This is questionable, I admit.
Personally, I have no problem with that, and although, as you say, an echo can usually be obtained quite quickly, and okay, it can be done as soon as possible, but in a patient who does not respond to quite a large amount of fluids, adding a little bit of dobutamine, not 20 micrograms per kilogram per minute. No, just a few micrograms per kilogram per minute is quite safe, and it may sometimes help to accommodate the fluid administration.
Indeed, the amount of dobutamine he was receiving at that time was 5 micrograms per kilogram body weight. It's not obviously not that much, but still, I think that we should
don't give too much. Otherwise, you may actually have a greater hypotension if the patient is hypovolemic. So just a few micrograms per kilogram.
And probably do have some monitoring more would have been helpful in order to better understand the picture. This was not done, and I blame that.
I have to agree that I disagree here. I mean, I don't disagree on the principles that dobutamine may be given at some point and even in the early stages, but we need some figure to document that we need it. I mean, if you measure the SVO2 at that time and it is 85, would you give dobutamine to this patient without an echo? Well,
if the delta PCO2 is high, maybe.
Yes, but then this means that you need additional numbers. So without these additional numbers, I would not go, and especially knowing that when you perform regular echo on these patients, you sometimes, and this is up to 1/4 of the patient, a very nice trial from Michel Sama, you disclose in these patients that you may have obstruction of the left ventricular outflow tract that occurs because of the vasodilation, because of the hypovolemia. All these factors together may play a role, because of tachycardia also. So when you have obstruction, you will even impair it. So without an echo and or an SVO2 at least, or CVO2 at least, or a PVCO2 gradient, I would be more reluctant to give dobutamine right away. And I think that we need more data to give dobutamine, or more time and more fluids before giving it. And otherwise, remember the Leopard's trial, it was not dobutamine, I agree, it was just levosimendan. But giving levosimendan in this kind of condition was not helping these patients in a randomized trial.
However, you must admit that the levosiman story is the very, very beginning.
It's a different story, yeah?
And it's a different story.
The examples that giving
No, but they gave it routinely. We don't know about the fluid administration. Here we have a patient who does not respond to 2 liters of fluid. Okay. So you may suspect, I can understand that, in view of the severity of the process, the atrial fibrillation, that this patient actually does not tolerate fluid because there is a myocardial problem.
Yeah.
And it's very safe to give a few micrograms per kilogram.
This was the clinical deduction of the doctor in charge. But again, as he said, probably having some monitoring more wouldn't be helpful.
But I'm sure we will have the echo and the SCVO too.
Do we have a comment there?
Yeah, I think I do agree with Prof. Vincent that Leopards is completely waste of time or different kettle of fish. It's a different question because it had been happening for all comers rather than just particular patients with septic cardiomyopathy. So
is that exactly what I'm saying? It is, these patients may not have septic cardiomyopathy. So that's why it is an all-in-comer, and you are giving the butamine as they were giving levosimendan in that trial. That's why, I cannot comment on the adequacy of it in this specific case. I just say that in general, I would not go for the butamine without other numbers. Maybe here, at the bedside, they have other information that we do not, that are not presented here, and that totally and fully justifies the use of what was done. It's just, if we discuss on general, from the information we have available at this stage, I would be reluctant to do it. This is just
I think another point that discussing together and preparing this case would be helpful for the audience is just to try to understand and having a better insight regarding this following recommendation, where within the, again, the Surviving Sepsis Campaign recommendation, it says that we recommend that following initial resuscitation, additional fluids may be guided by frequent reassessment of hemodynamic status.
Our colleague from Russia would
yes, please. Sorry.
Hello. I guess the additional concern with giving dobutamine is this patient also had atrial fibrillation and flutter, so you're giving a beta agonist and potentially exacerbating that condition and then potentially exacerbating hypotension. So that was just the comment on the dobutamine.
Dobutamine and atrial fibrillation.
Okay. So your concern is regarding the presence of atrial fibrillation and the adding the dobutamine. This may have also worsened the atrial fibrillation. This is your concern, which is in part true. Is one of the possible things. Remain to understand if this kind of dose that we were alluding to, 5 micrograms per kilogram body weight, would indeed influence that much the presence of, or just compromise even more the cardiac function.
Although the tachycardia is not necessarily so harmful. People look at it and say, the patient is getting tachycardia. There's a 42-year-old gentleman without any history of coronary artery disease. At 42, you can manage a relatively fast cardiac heart rate.
But the point I think that is very important, and Daniel wanted to stress about that, when there is this kind of recommendations, the real question is, in practice, what have we to do? Yeah. And so this is a question that we ask you, and then we continue with our consideration. So what should you do?
So, as again, the recommendation is a frequent assessment of hemodynamic status. What is exactly frequent assessment of hemodynamic status? And
some of these recommendations or parameters that were included into the remarks are very, very generic or simple. Mm-hmm. Let's move on. Variable to use further fluid administration. Would you like to comment that?
Yes, I mean, I think that we can move here from the simple one, which are indeed the one you can have at the bedside with just, let's say, your hands, which is the skin mottling, the heart rate, blood pressure. But these are more triggers for doing something than real variables that helps you to say that you need to give fluid and that this patient will be tolerated by this patient. So perhaps the same is true, of course, for the lactate and even for the veno arterial PC2 gradient.
But before going on, I would like to ask to the audience if there is anyone here in the room who used the so-called Motley score, and then we show you, for those who do not know it, what is it? Is there anybody who utilizes this kind of indicator?
Well, it's relatively subjective, and
it is relatively subjective, but you know, as in the recommendation is also suggested to look at clinical indicators, this is something that can be helpful.
I would prefer to look at SCVO2, which is not on your slide. I mean, you speak about VA-PCO2 gradient, but not SVO2. It should come first.
Yes.
You should look at SVO2 before looking at veno-arterial PCO2 gradient.
So the SCVO2 is in the other available hemodynamic measurements, because it cannot be recommended to absolutely measure SCVO2, even though we suggest, and I strongly suggest for my colleagues to measure SCVO2 when the central line is in present, we need to measure it.
So I didn't speak about early goal-directed therapy. Eh? Okay, no. We should not apply early goal-directed therapy.
No,
but it does not prevent you from looking at SCVO2, exactly as you should not target a given arterial pressure, but you should measure arterial pressure and heart rate the same.
Hey, gentlemen, I think that we need to clarify an important issue, because if you look at the indication coming from the last papers that in a way or another abolish the concept of the early goal-directed therapy, nonetheless we must admit that these papers use the formal protocol in the control group. Then exactly. There is something that was applied to these patients systematically. Exactly. We cannot say that was so-called generical, usual practice. It doesn't mean anything. It was a protocol, so it means something. And in addition to that, I think that even though the strength and the validity of a parameter as VCO2 is not 24-karat gold, nonetheless is something useful. It's one of the parameters that in combination with others can help us in guiding therapy and just giving the right fluids to these patients in the right moment and just to assess better the presence or not of hypoperfusion. One of those parameters, not the only one, not the single one, but one of those. What do you think? Any comment on that?
Totally agree. I mean, you just remember for the audience that this session is a session discussing the guidelines, and these are in the guidelines. The SCVO2 has left from the guidelines, is no more mentioned in the guidelines, except in a negative way. So I think that we are here as experts to say that we can measure it, and we can still have information from this.
It is true what you're saying in terms of recommendation, but if you look at the rationale which is contained, this is better explained what is behind. And then the real problem is that often people do not read the remarks and the rationale, and so may miss important information that are there contained.
As I said yesterday, it was difficult to reach consensus when you have 59 people who have to agree on something. And so people said it's only the evidence, only prospective randomized controlled trials. And the randomized controlled trials on early goal-directed therapy are negative. I had a lot of arguments with Jeff Drazen, the editor-in-chief of the New England Journal of Medicine. We had an extended email correspondence on this. He was saying, Jean-Louis, you don't respect the evidence. You don't respect prospective randomized controlled trials. I say no, but I still treat patients, and so I need to look at some variables, even though simple protocols may not work so well.
However, we all agree that the best way of having a consensus is the consensus of one.
Yes. So about consensus, it's time to discuss with the surgeon. So I think that before insertion of a central line, in addition to heart rate and blood pressure, lactate and...
We need a surgeon.
Yes, no, but lactate and echo is a good way to guide resuscitation, and I will leave the junior resident insert the central line and have a look at the SCVO2, and I will discuss with the surgeon about the case.
We are still in the hemodynamic resuscitation, but of course there is the infection control there.
You see, I think that at times
more than the infection control, I think that Jack would like to make the point that we have head and neck infection, and so maybe the insertion of a line in supravena cava is not feasible in this patient because of the infection close to the vessels.
Did you say that?
You want to mean this?
He didn't say that, but you are right, but he didn't say that.
This is an important point, but
Daniel, it was not exactly this, but in this case, I completely agree with Daniel, and the femoral access is a good one, and even if it's not a central SCVO2, you can deal with venous saturation at the femoral level.
Another important point that I think we should clarify, and it's never stressed enough, at least in my opinion, is that when we look at the recommendations and this kind of situation, we start to believe that we have a process that is just differentiated in different steps and different times. But very often, and with everything, occurs simultaneously. So you have the consultation of the surgeon, you have the insertion of the central line, measurements of SVO2 or lactate or whatever, and your action. So it's different than to say, oh, you should first call the surgeons, or you should first put a central line, you should determine that or that. Everything happens at the same time. And which is very important, but it never is so clear looking at the recommendations, whilst in the real life it happens that way.
And you need someone to coordinate the things and to think at
these
different things and to ensure that everything is done.
And you know quite well that this role is often assigned to the poor intensivist. It's not that easy at times. But I wanted just to show, and then we'll come back to the essential. These patients, just for having with the surgeon the CT scan, this was the situation. But let's show you, and then we'll come back to the initial, what was the real status of the trachea and the reason why we call the surgeon immediately. Look at that. It's something unbelievable, really unbelievable. You see, there are areas of necrosis of the mucosa, and there are some holes in the pars membranacea. So a situation that as soon as we realized that was under these conditions, we were very pessimistic regarding the evolution of this patient. Despite he was operated and they tried to have a closure of these solution of continuity through the plastic of the, and it was unbelievable because this was generated by a dental abscess and mediastinitis. During my life, it was the second time that I saw a picture like this. Really unbelievable. So we can come back to the original slides just to continue. Okay, we were speaking about the Motley score then. And the other parameters.
So I think that when we discuss indications for the fluid assessment, there is first the trigger, and there are several triggers there that we may consider, including urine output and so on, and lactate and VPCO2 gradient. But then we have also the indication for giving it or not. And in the campaign itself, it's relatively limited. I mean, in some other lines, there is mention that we should use dynamic more than static variables whenever applicable. It's clear that in this early stage, in this patient, it's very unlikely that the dynamic variables are easily measured. So that indeed, what we probably will do is a free challenge, but let's say a soft one, because we do not have a lot of variables to evaluate the response to fluid either. And so it will be mostly looking at the response in terms of tachycardia, maybe, but this patient is in atrial fibrillation, so not so easy to look at. The improvement perhaps in blood pressure, which is not the best one, but which will be probably the only one that we have as a bedside, and maybe CVP if it is measured in this patient.
Well, cardiac output is not on the slide either, but you could look at acute changes in cardiac output during your fluid challenge, but you must have a reliable technique for that, and you cannot use less reliable ones.
some of these techniques may be also less valuable because of the presence of atrial fibrillation, of course, and then being less reliable. However, one thing that is at least useful for the audience is the reminder that when an atrial fibrillation is present in coexistence of a septic conditions, then this is an indicator of poor outcome. It has been shown several times into the work, and it's indeed a very poor outcome. All those patients who develop during their stay into the hospital and in consequence of an infection or in relation to the infection in atrial fibrillation, they are more prone to have a bad outcome.
A worse outcome. I don't think we can say a poor outcome. I don't want people to give up, say, the patient developed atrial fibrillation, everything is over. No. Outcome is worse.
Probably not.
Whenever anything is abnormal, the outcome is worse in any case.
Okay. Any other comment, or there is any other comment coming from the audience?
No, I think in these patients, the echo is really one of the things that I would like to do rapidly at the bedside, because it will help me to confirm that we can give the butamine or not, to help us to evaluate the response to fluid and other things like this.
It was done at the very beginning. That is why there was also a fast proceed toward the intubation. Then this is the Motley score again that has been shown in this publication into the intensive care medicine, that the extension or the size of the Motley was put into relationship with the poor outcome. Please.
In this case, did you actually manage to get an echo? Because with this picture, it's also difficult to get good views if you're in the...
You mean an echocardia?
Yes.
Echocardia. This indeed was not done because the patient was moved immediately, was performed in conjunction with the decision taken with the surgeons after the bronchoscopy, was immediately moved to the OR in order to try to treat the situation. The other point we alluded to, veno-arterial PCO2 gradient, and I think that is important just to have some comments on that.
Well, the interest is not only that abnormal is associated with a poor outcome, but it's also a dynamic factor. And then when you are able to at least improve it with your resuscitation strategies, this shows that indeed in the second line here with a H and then L, meaning high initially, low after, these patients have a relatively better outcome. So this means that even though we do not have good trials to say that you should target it, it's a good reason to at least try to improve the solution and to follow it as well as the lactate. When it is decreasing, it is a good in this that the patient responding to the therapy, and so when the gradient is decreasing, this also is an indicator that you are going in a good direction. And when it goes the other way around, you should be more and more concerned.
But again, I think that what we do in the real life is just to look at the combination of these various indicators, and I think that our colleagues into the audience do the same. If someone wants to make a comment concerning that, do you use a single parameter to look at, or lactate, for example, or you try to have a combination of all these things? Don't be shy. Okay.
So I think it's better than in some places, because when we discuss lactate, it seems that everybody measures lactate.
Yes, indeed.
Because when we discuss at some other point to implement lactate in some definitions, lactate cannot come because everybody do not measure lactate. And in large database evaluating sepsis in US, sometimes you miss lactate levels because lactate is not measured in these patients. So we need to be careful for this.
Not only careful, but also realistic. Please. What did you say?
I disagree because we always use lactate. It's one of the parameters.
Yeah, it's a quality indicator now in the US, and you could have medical legal problems if you don't do it.
But this is the other point. When you develop some recommendations, theoretically you should think to something applicable everywhere and in any different contexts. And at times there are places where lactate are not measured, in others where it represents a quality indicator. So there are a large variability, and we have to take into account when we recommend something that this can be realistic done almost everywhere. And this is the other point, the limitation. We do have evidences, but not all. we know that one of the activities of the Surviving Sepsis Campaign is the application of this principle in countries with less economical resources, and where obviously not all the tools that we have are largely available. And this is something that we have to think about, I think.
Yep.
It's a responsibility that we have to take. Fluid therapy. This is another point that I think it opens a huge discussion, because there is the recommendation of the fluid challenge, there is the recommendation of using crystalloid, there is the recommendation of use some additional fluids in order to keep the volume replacement therapy under control when the saline solution, the crystalloids, are not good enough. What do you think? Never mind if you don't finish the case. I will show you the final outcome, but in the meantime, it's a way to stimulate the discussion. Which kind of fluids do you use? Do you stay with the recommendation of using crystalloids?
As people think about it, I noticed that you already gave 2 liters of saline.
Yes.
As I will discuss in my talk a bit later, we must be careful about the administration of too much saline, especially when the chloride levels start to rise, because that could be bad for the kidney, as we will review. So I would not choose saline again unless the chloride levels are not very high.
That's correct. And
I may use Ringer's lactate or
Yes.
plasmalite.
Ringer lactate would be another solution.
It's a bit hypotonic, but in this case, it doesn't hurt. I mean, it's not head trauma. You could use a hypotonic solution. Don't forget that the Ringer's lactate solution is a bit hypotonic. If you call it Hartmann solution, Hartmann was a pediatrician treating children with gastroenteritis. We'll review it later.
Let's be provocative, and shouldn't use anymore some colloids in alternative. I'm not speaking about albumin, other form of colloids.
Again, with the Surviving Sepsis Campaign guidelines, we wanted to be along with the evidence, and there is no real evidence that we should give colloids early on. But we would give colloid early on if we start with a patient with hypoalbuminemia. We would give some albumin from the very beginning, but not in all patients. So we need to adjust the type of fluids to the clinical situation and not have formula which are applicable for all patients.
But this means that you measure things and you interpret your measurements, and based on your measurements you will change your decision. And so if you have no measurement at all, probably you will keep with the recommendation.
Unless it's a cirrhotic patient, for instance, but that's not the case.
Yes, but it's different. We are speaking about specific subsets of patients. When you say measuring something, would you elucidate your mind?
In my mind, I measure chloride, because indeed the discussion about saline and plasmalite will be based on chloride. If by chance, and this seems not to be the case, the patient not vomiting for 2 or 3 days because it's something there, then maybe hypochloremic to begin with, and then of course giving more saline may still be indicated in these conditions. But it's very unlikely at this stage, because of what you mentioned.
He had metabolic acidosis at the beginning.
Yes.
Remember, 7.34,
So
despite hyperventilation.
So we don't have evidence for this. But I was thinking a more general aspect. I mean, the same is true for the albumin. I mean, it is unlikely that he has severe hypoalbuminemia at this point, but probably this will occur relatively rapidly, and we may consider indeed to give albumin. The question, I think, is more on the other colloids than albumin.
Yes.
Do we have some room for giving the other colloids?
The starches, for instance. Would you give starches to this patient?
Well, that's a long story. I think
I know that it's a long story, but you know...
We have just a few minutes left, but I think we have been probably too strict about hydroxyethyl starch, but nevertheless, the consensus today is to avoid giving starch solutions to patients with sepsis. So I would respect these guidelines, and I would not give hydroxyethyl starch in patients with septic shock. Although hydroxyethyl starch solutions may still have a place in other types of patients, including in the perioperative stage, in patients who are acutely bleeding. You can give a limited amount of hydroxyethyl starch, especially if it's cheaper than albumin where you live. In the US, I would not give it because it's the same price as albumin or hardly cheaper. So what is the advantage now? But if it's clearly cheaper than albumin, maybe a place in some conditions.
So in practice, there is always a discrepancy between what is recommended through the randomized clinical trial evidence and what we do at times. I think at times with a wise approach, being balanced between the recommendation and what it happens in the real life. And a combination of certain fluids may be possible, even though some recommendations or some evidences are strongly against. But the context is different. One thing may be to give starches in the OR, for instance. It doesn't mean that the recommendations are against. Another can be large amount of starches to patients who are septic and where the possibility of inducing a deterioration of the renal function is very high, but it's another story. And at times, it becomes a sort of potpourri. We put all the things together and people immediately say yes or no, but it doesn't work that way. It's different. Going on, what about the use of albumin? What do you think about? You alluded to that, but would be the audience in favor of adding albumin when the amount of crystalloid that should be given isn't it very huge, large? Should you do that?
Well, we are living in Belgium, you are living in Italy, and so these countries are perhaps among the top countries using albumin, but I would like to ask the audience, where a lot of people come from Asia, do you use albumin in Asia? Yes. Okay.
When?
And so would you use albumin in this case? Yes, okay.
Okay.
Okay. Yes, please.
Yes, please.
One thing is, albumin is extremely costly agent, even in Asia. And the amount of albumin which is required to use in such kind of patient, if we take an example of Albios trial by Italian group, it's a very high amount of albumin which is used for a longer period of time to reverse the septic shock or sepsis patient. So it's extremely costly affair to use albumin in a recommended dose for a recommended duration of time. So it's very difficult to use albumin in our setup.
And not using it, what you should use, or at least what you do in India?
We use primarily crystalloids, and sometimes albumin, but very rarely. I would say 1 in 100.
The other colleagues over there that want to say something.
Hi. I'd like to ask, when you say using albumin for initial resuscitation, you are using 4%, 5%, or 20%? Because 4
this is
5%.
This is another good question. I would say that, for instance, in Italy, and the only study that we perform in randomized trials with a huge enrollment, we used 20% albumin, not 4% albumin, which may make the difference for various reasons, including the fact that albumin, yesterday we had a specific talk on that. Albumin may also have other so-called pleiotropic effect that can be beneficial in addition to the capability of being a fluid for the replacement therapy per se.
So when you use for initial resuscitation, we also use 20% albumin?
When you do not want to give too much fluid, you use the 20 or 25% solution. If the amount of fluid is not an issue, then you can use the 4 or 5% albumin solution. In other words, if your patient is already edematous, if you would like to reduce the edema, you could use the 20% albumin. In cirrhotic patients, you would use the 20-25% albumin, whatever you have available. But if you are in the fluid resuscitation process, you could very well use the 4 or 5%, which is just a diluted form. You have the albumin plus a solution containing salt that you give. So whether you give the 20% albumin and a crystalloid solution in a Y system, or if you go 4 or 5% albumin, is the same thing.
But the 4 or 5% albumin also has a lot of chloride. Am I right?
Yes, indeed. Yes, indeed. But you will not give too much of these solutions. You will give, in our country, 400. In many countries, 500 cc's. So it's not a big amount of chloride.
Thank you.
We must also admit that one of the other concerns regarding the albumin use is that often these patients do have a capillary leak, and a large amount of albumin may come out. We have time just for the last question, and after that I want to show you the final bronchoscopy that explains how the patients went.
Back to the albumin. I just wonder if you're using 20 or 25%, how much volume are you giving actually, at how fast the rate? Thank you.
You see, in this case, what we usually do in clinical practice is use something like 100 or 200 milliliters of 20% albumin and see what happens. This is the real practical issue.
Well, that's a question of the rate of the infusion, but it's based on the hemodynamic status. As I will show you later, if you use a colloid solution, it will remain more into the intravascular space. You must be careful, because if you give it too fast, you will have an increase in cardiac filling pressures with possibly more edema formation. So if your patient is already normovolemic, be careful, give it relatively slowly.
I think that we can anticipate that looking at that initial picture, the possibility of repair, that damage was very poor, but I wanted just to show what happened in the evolution and despite the surgical intervention.
You sure the technicians
can I get back to...
Okay.
Okay, sorry.
So in the meanwhile, I can continue to discuss?
Yes, of course.
But so I think that we were discussing the albumin, but on the albumin, finally the positive trials were mostly using the concentrated albumin. It was the Dubois trial, it was the Albios trial, and all these trials were these positive trials were using the concentrated one. Even the SAFE trial was using concentrated also. Yeah. So I mean, at the end, if we give, I mean, considering the amount of chloride, considering
I have to click on the last video.
And so,
please.
Agreed, but again, if you give the concentrated albumin and if you continue with a lot of crystalloid, it's the same as giving the 4 or 5% albumin. So the question is not really very important.
It's more convenient.
Any other comment? However, what the surgeon tried to do was a sort of plastic of the trachea.
Who has gelatins available in your country? Can you raise your hand? Gelatins, raise your hand. Maybe 1/3 or so. Okay, thank you. Because we didn't know what to say about the gelatins in our guidelines, because as you know, there are not many studies on this. And so some people were against, some people were in favor, and so we said, okay, let's give crystalloids as a preference to gelatins.
This is the video and the final evolution of the case. Please put attention what happens to the upper part of the trachea. What happened? It's something unimaginable, because the endotracheal tube was moved in order to expose the surface in a proper way. The hole was not repaired at all, because there was a reopening of the trachea, but even more, happened something really unbelievable. Look at that, just in a minute. I should go in the very first, yeah, look at, here it is. Just removing the endotracheal tube, you see that the trachea is totally disconnected. And so it is obvious that under this condition it was absolutely impossible to save this patient, and in fact, unfortunately, died. Yeah. Thank you very much.
Yeah.